under 45 to 60% in people over 65 years. So given that, we really can't afford to ignore the need for physical health assessment and care for older people with mental illness, and integrated physical and mental health care really is, as they say, core business. Looking at mortality in older people with mental illness, each year more people aged 65 to 85 years living with mental illness, which is the blue column there, die than the rest of the population within that age range. So early death is a significant risk issue for older people with mental illness. And if we look at the treatment patterns, the percentage of people accessing MDS and PDS mental health treatments goes up for people 65 plus years, but note that this is mainly due to higher rates of medication in older people rather than psychological therapies, and there are lots of challenges in older people accessing appropriate psychological therapies, and that can be problematic, of course, for physical health care around falls and multiple medication use. The relationship between physical health, mental health and mortality risk is complicated though, and changes in mortality risk for people with mental illness aren't actually simply age-related, of course. Still, it's clear that poor physical health is the largest contributor to poor mental health in older people, as this large cross-sectional study by Lauren et al. Shows, and that underlines the importance of integrated physical and mental health care in older people to address both the mental health risks and the physical health risks. So looking at the international literature, what do we know about the physical health needs of older people with mental illness? Well, we know that some psychiatric medications increase the risk of a range of physical health conditions. This is not new to any of you, such as diabetes and cardiovascular disease. We know that older age and polypharmacy, which is common in older people, as well as higher dosages, are associated with increased risk for most of those diseases. And I've already noted the association between physical ill health and mental ill health in older people. This New South Wales Health guideline for mental health services about physical health care for old mental health or for mental health consumers highlights, in fact, some of the particular risks and challenges for this group. So risks associated with falls and multiple medication use, for instance, potential challenges around obtaining an accurate and complete physical health history, and the importance of considering delirium in older people presenting with apparent psychiatric conditions. And we know that this kind of more specific guidance is important because there are things that are different when you're treating older people from younger people. And drilling down a bit further, this Danish study of older people with schizophrenia found that this group had a similar profile to the control group in terms of chronic illnesses, but were much less likely to receive medication for cardiovascular diseases. They also had similar patterns of hospitalisation to the control group, but much less primary care, much less GP care. And a Dutch study of people with schizophrenia found that excess mortality associated with schizophrenia continues into later life, affecting men more than women. So there's something to look at there. And closer to home, this isn't summarised on the slide, but a major Western Australian study of older men with depression found that they had a higher risk of hospital admission for non-psychiatric conditions and were more likely to have longer hospitals admissions and worse hospital outcomes. So that potentially highlights a potential area to target health interventions for that particularly high-risk group. So if we're thinking about areas for implementation and for action, let's look at some of those high-risk groups. A number of studies also highlight the high frequency of metabolic syndrome in older people with severe mental illness, and this Canadian study of older people with co-occurring anxiety and physical health conditions highlights that the complex connection really with mental health service use. So, getting to how are we going in terms of meeting physical health needs of older people with mental illness? Well, the answer from this study in the British Journal of Psychiatry of older people with schizophrenia is not very well. This study showed under-assessment and under-treatment of physical health conditions despite the known risks. And this UK study looked at clinician attitudes towards older people with severe mental illness and physical illness, and it found that clinicians found this combination challenging, that they're unclear about different responsibilities. So this echoes some of the themes we heard yesterday, and they feel they need more collaboration and more education. So let's talk about how older people's mental health services are responding to physical health needs. This is national honours data for older people's mental health inpatient units. It shows that in the course of an inpatient stay, the clinician-rated health status of most, that is about half consumers of older people's mental health inpatient services, stays about the same. More get better than worse, which is encouraging, but there is a small group that gets worse, and it's for those that deteriorate in inpatient care that we really need to look at what we can do to prevent that deterioration. And this slide tells a similar story to the last slide, but it relates to activities of daily living and physical function. And again, for those that deteriorate in terms of ADLs in inpatient care, we need to look at what we can do to prevent that deterioration. And this is the kind of information that we look at within our older people's mental health services in our benchmarking strategies, and Rob will talk a little bit about that. So for a few more insights about how older people's mental health services are currently responding to the physical health needs of consumers, and again Rob will talk about this in a little bit more detail. We have a statewide older people's mental health benchmarking strategy in New South Wales, and as part of that we have developed self-audit tools for our community and inpatient services, which outline some good practice standards in a range of areas that are aligned with statewide evidence-based models of care. And we conduct self-audit processes annually with almost all teams across across New South Wales opting into the process. So there's a high level of engagement with this. And the results of those self-audit in terms of physical health issues show that older people's mental health services are challenged in a number of standards relating to physical health care. So they're challenged around the involvement of GPs. They're challenged around access to nursing staff trained in IV medication and fluids and subcut fluids in inpatient settings. They're challenged around physical examination of older consumers, particularly in community services, and they're challenged around actions about falls prevention, especially in community services, less so in inpatient services. And we've also had a recent independent evaluation of our initial implementation of a statewide model of care for our community older people's mental health services. And that confirms from staff survey and so on the challenges our clinicians are identifying around physical health assessment, around accessing skilled staff for assessment and management of physical health issues, and some of the other self-audit tool findings. And we can get some more insights from consumer experience surveys. So in New South Wales, the measure of consumer experience of mental health services, the Yes, Your Experience of Service questionnaire includes a specific set of questions about physical health care. And I think in our conference bags you've got a copy of that Yes survey with the New South Wales specific questions. And the Yes survey results for older people's mental health services give us a bit of an insight too. And they show that in general, older people's mental health services provide a high level of information and advice to consumers about healthy eating and diet and exercise and physical activity. This is as reported by consumers. They provide a medium level of information about possible side effects of medications. That's slightly better in our community services. About alcohol and drug use, again better in community services, and about smoking when that's relevant. They provide limited information and advice about sexual health. And overall, despite all of that, which you might see some gaps in some of that information and advice that's provided in the physical healthcare area, people are overall have a very high satisfaction rate with older people's mental health services. And that echoes the UK study that I mentioned earlier. So, to summarise in terms of implementation action and what all of this means for care, our ageing populations means that we need to be geared up for addressing the needs of a growing group of older people, and older people's mental health and physical health care is a growth area for us. In considering how and where we target our action, we need to consider the needs of different subgroups of older people. All older people are not alike. And apart from individualised care, we need to look at the needs of different groups. So the younger old and the older old may have some different kinds of needs, and different sorts of strategies might be appropriate. Given the high levels of physical health and physical and mental health comorbidity in older people, integrated care is really a no-brainer. We need to understand the risks and complexities that are specific to older people with mental illness. And as I said earlier, this is often a gap in policy and practice guidance. There's often not so much consideration of how this guidance particularly applies to older people. And given the evidence from the literature, we could do worse than improving assessment and treatment in known physical health risk areas, such as cardiovascular conditions. And we should look at, within our services, at older people's mental health services, at our attitudes to physical health care and collaborative care, at our staff skills, mix and staffing profiles, at collaboration, particularly with GPs, and advice to staff to consumers on physical health issues, on things like medication use. And I'm really going to finish with this slide because it's a bit of a taster for Rod's presentation and also for our workshop this afternoon. This gives you one kind of framework for looking at implementation priorities. And Rod's going to talk you through the implementation journey that we've had in New South Wales in this work. Thanks.
It's very interesting. I don't think we focus enough on older people, mental health or physical health in our community, to be honest with you. But so I'll be looking forward to having a chat with you later, Kate, so that's good. What we might do is we'll get Rod to come up and do his presentation, and then we might take questions on either presentation. I'm not going to read all this out, Rod, if you don't mind, but Rod is a psychiatrist with a passion for improving mental health practice and quality for older people with mental illness across all ages. He's been involved in this for a long time. He's been involved in education training in New South Wales, and he's chaired a number of expert advisory groups. So, over to you.
I'm going to start. First of all, I would like to acknowledge the acknowledgements that have happened already. We're not actually saying acknowledgements. I think we need to think about why we do acknowledgements, that we do them for a real reason. We acknowledge people, and we acknowledge Aboriginal people who have experiences that make a difference to each work each day in what we do. I'm getting confused. I just keep coming, what acknowledgements are, not just to repeat them. That makes some sense to me. And so why am I talking? Why are we doing this? It's because it's about people. And so we talk about systems, we'll talk about figures, we'll talk about things we do, but it's about people. And in terms of improving mental health, improving physical health, if we can keep that in the centre and that each person is different, we're off to a good start. And I have had many roles, and I think each of those roles in a different way is going to influence what I'm going to talk to now. In particular, I've been a clinician, still a clinician. I've had to run services. I've been doing advice with the policy unit now for quite a while, and also I'm a member of the community, so I hear what people say, and I think sometimes we forget that we need to bring those things together. as we look at this effective action. And I've also been looking at the interface between mental health and physical health for too long. And if I think about the journey overall, what I'd say is from a point of encouragement to a point of discouragement in terms of myself to growing encouragement again. Particularly with regards to older people. Older persons' mental health services, as I was trained, and I have to acknowledge that it's now a long time ago, long enough to think about, started from total integration of physical and mental health care. But the services were very small. Older persons' mental health services in general across Australia haven't actually kept up population growth as much as other services, but they've still grown a lot because the older population has grown a lot. And in that time, the skills mix and the culture of older persons' mental health services has changed. And in particular, the integration between physical and mental health care and the attitudes to that has changed, and it is not as strong as it was, but we've been looking at how we rebuild that. That's really what I want to focus on, how do we rebuild that? The other journey I've had is also the journey of, in New South Wales actually had the first statewide policy and guidelines around the physical health care of people who are consumers of mental health services. And because I was the older person's advisor, I was handed that in a meeting where I couldn't say no. And I was told, oh, it's just about physical examination. So the reason I flagged that is one is that's about 10 years ago. Those guidelines, as we developed them, actually clearly were not just about physical examination. The other important thing about them was that they were clearly not just about older persons' mental health care. And over those 10 years, they've moved from being something where the attitude of services wasn't about examination to where now the attitude of services, even not all the practice, is about bringing together physical and mental health care. So we've come a long way in 10 years. But systemic improvement is difficult. Systemic action is possible. Still difficult, but possible. But there's factors that increase the likelihood of actually that being effective. And in terms of older people, we need specific actions. They can't be just the actions that are for everybody. And I'll show some figures which look at some pictures and figures about why that is. We need to improve the evidence base of what actually works. So we know a lot about what is there, but what works to actually improve care. And we need to work collaboratively to build up trust between partners, because no one section of the healthcare system can do this, no one clinician can do this, but, in going back to one of the comments after the last session, everybody can start somewhere now. And in terms of what we're looking at systematically and systemically in New South Wales, that last message is probably the really important one. And we're starting a project based around that. So, very quickly, national perspective. Why do we have to start somewhere now, and why am I not going to say to you, this is what works, is because variation is the rule. Variation is the large in all healthcare, but I'll show you particularly when I think about older people. And that's vital if you think about implementation. Because if you think what works in that population is going to work in yours, and you're just going to move across and do it, you're probably going to be disappointed. So I'm going to look at particularly information from the New South Wales Mental Health Commission's data analysis, and also the Australian Access Healthcare Variation. And also some data that comes from Medicare. So first of all, the pattern of access to care changes with age. And so if you look at this, and in particular you look at older people, you see that in terms of Medicare funded services, so take the data where you combine Medicare and PBS together, this is just look at the Medicare funded services. What you see is that older people get less and less Medicare funded services as they grow older. And if you go over 65 and you hope to see a psychologist in Australia, you'll want to be very, very, very bereaved. What does that mean? That means that in terms of the sort of care that people get for their mental health condition changes markedly with age as well. And so this is New South Wales data. You'd be very surprised that the pattern is very different as you go across the country. And what it shows you is that if you're younger, you're most likely to get services, across all ages, there's a chance you'll get both. But in general, the younger you are, the more likely you are to get talking therapy. The older you are, the less likely you are, the more likely you are to get medication. And if you happen to not live in a city, then you've got real problems in terms of access to treatment. So, but why is it important? This is the context. If you want to improve physical health care, you need to think about the partners will be different and the care people will be receiving will be different. And I said, well, you think this will be the same across the country, and the big pictures probably are, but what we also know is actually this huge variation in mental health care in terms of where the data is around medication use as you go both within states, but also there are some things that change quite markedly from state to state. We don't know why. Whole others talk about the why, but again, it's why we can't expect to pick up a solution from one place and just put it somewhere else and expect it to work. We have to understand what's happened for us locally. Why am I showing pictures? Because actually the information about what is happening locally for most people is now there publicly available. But we don't often enough go to look at it. The Atlas, you can go down to your PHN or LH, local health district level. If you want to look at what is the characteristics of your population, the census data is now available. So you can just go and click on your area and find out a huge amount about the population you're working with. And that's what we need to do if we want to get effective treatment and effective interventions. Anxiolytics, there's even more variation. The next thing is, and Kate said, older people are not all the same. And this is looking at inpatients, older inpatients, and looking at people in terms of the diagnosis that's been placed against them as the primary problem in the data sets for outcome measurement. And the key thing there is first of all, there's a significant group who don't have diagnosis. The next is there is people with mood disorders stay about the same, but there's a clear swing for people with most with organic disorders and psychotic disorders. So as you get older, people coming in contact with mental health services change in terms of the primary problem identified. That's just diagnosis. It may or may not tell us something. What we can look at, though, is actually what sort of care supports are those people identified as needing, and this is using the instrument that's rated by mostly nurses as they come into inpatient care. And what it shows you is there is a marked change if you look at people who are aged 65 to 74 and those over 85, and those in between in ages are in between them. The change is huge. The care needs are hugely different. If we expect to do an intervention that is for all older people, we are not going to meet the needs of the different groups. And if we look at the broader honest data, the key picture from this actually is the fact that in terms of the clinical problems, so if we look at symptoms, they don't change so much. So even though the diagnosis changes, even though the care needs of the person in terms of their physical health and activities of daily living change, actually in terms of the symptoms, they stay about the same. So again, when we're thinking about what this group is like, a diagnosis doesn't tell us their care needs. The age doesn't tell us their care needs. We need to understand it for each group. That groups will have significant differences. The other thing to think about with older people is recovery remains relevant to older people. But there's only one study that has so far actually asked older people about actually what they see as recovery meaning in the UK. And the overall phrase they used to describe it in terms of what was both similar and different is recovery they saw as continuing to be there. The issue being that older people already have been through an awful lot of problems, often before they've had mental illness or if they've had mental illness, they've learned to cope with a whole lot of problems. They have an identity, and mental illness is just one more part of that identity. Again, why is it as important in terms of physical health care? What that means is, if we're looking at interventions that we're trying to take from adult mental health into working with older people, adult mental health interventions are often based around the concept that the person has got a lot of contact with the mental health service. The mental health service is in many ways the main healthcare provider. That is often not the case for older people. Again, it changes the way we view interventions. The other key thing in terms of recovery is that actually as older people develop cognitive impairment, they both do rely on and they want to rely on the person who is their primary carer and the person who's closest to them to help them maintain their identity and to work very closely with them. So again, some quite different concepts about who might be working with if we're trying to improve physical health care for older people. And Kate mentioned polypharmacy, and I don't think it's harmful to actually look at the degree of increase in psychotropic medication prescription for older people. It is really quite horrifying. That includes a whole range of psychotropic medications, but again, coming back to physical health care, and if we're thinking of physical health care, the role of medication is really important to think about in terms of interventions. And why we're still talking about this, I think it's hard to go past this. So this is actually a study that was done by the Human Rights Commission, and it looked at the way that older people are portrayed in the media. And there's the work out that pulls out what are the key things, the key words. And that's then when they interview people about what the impact of that was. Now, the thing we need to remember is that when we work with older people, we work with anybody, we actually take on some of their perspective as well. It's not a one-way street. And so, if the community feels that way, we're going to take on some of that as healthcare providers about what we think about older people. And then if older people are feeling that way, then that's how we start to feel about ourselves as service providers and about our services. So going back to the talk about rights, we do need to remember the rights of older people to actually have services looking beyond this way and the impact that society has upon us. Again, if you're thinking about working with older people, you need to remember that actually the interface with the NDIS is totally different for older people. And it's not as simple as 65, it's not relevant, nor is it as simple as under 65, it is always relevant. The key issue today is to realise very different rules. So if you get interventions, you need to think about that. So, in New South Wales, we have been lucky because we've had a chance to actually have now a hopefully relatively coherent policy approach to older persons' mental health care for 10 years. The only state has managed to do that. We've had a plan, the plan's been reviewed halfway through, that let us then adjust our approach in the second half of the plan. We've also managed to develop models of care and evaluate those models of care. Within that, there has been a thread about what is easy to change and what is hard to change. And physical health care, unfortunately, is one of those ones that has sat in the hardest to change area, despite the workaround policy I've talked about already. So how have we tried to do what we've done that's relevant in that time? First of all, we have looked at the workforce, tried to understand what our workforce can do, what they can't do, what they feel they need more skills in. And we've looked at how we try to support them. And in that, we've identified that in the mental health workforce, there is less confidence in working with people with dementia than people without dementia. We've the broadest way of looking at that. Again, very different to what would have been 20 years ago. And that comment I had about the fact that services are different. We've also found some lack of confidence around physical health care skills. Benchmarking has been really the way that we have tried to look at our whole service development. The reason I bring it up is because it's actually the way we have established our standards of care, is by actually bringing together, first it was clinicians, managers and policy people into a room, 2 years really, discussing and trying to agree on what was good practice in different areas. So first of all, what areas we thought we should say is good practice, then actually define what that good practice is. That then went into the self-audit tools that Kate was talking about, so that every year services then look against their practice to see actually what they're doing, That then, with increasing consumer and care involvement as we go along, has developed into our models of care and continue to come back to the benchmarking. Why is it important? One, it tells us something about where services find change easy, where do they find it hard. Also, it's important because in terms of context of change, it does mean we're in a privileged situation of actually having a reasonable partnership between consumers, carers, clinicians, managers, and policy. And that trusting relationship actually is a really important thing. Now, to get all those takes a long time, and it's a real advantage. But having said that, you can look at subsets of that. If you're looking at subsets, you need to look at new interventions that work within that trusting partnership. What have we found? We have found that recovery orientation was difficult, and we looked at a action to do something about that, and I'll talk about that briefly, because that's the model for what we're now going to do about physical health care. We found the involvement of GPs is variable, better with inpatient setting than community in many ways, but variable. Physical examination has been a recurrent problem. We have managed to do action about falls, and quite actually, if you look at over 10 years, probably actually had at worst no change, and probably a slight improvement in falls, which if you look at the literature, actually is quite an achievement. And we found physical healthcare capacity with inpatient units is difficult to change. So, recovery, it was difficult. How did we then go about just talking about it in benchmarking, us looking at saying we're not changing, wasn't changing. So what we looked at was how do we develop a statewide project in an environment where we know there's a lot of variation and think about can we get improvement. And basically what we did is first of all we set up a project which had a steering group, which had all the stakeholders you would hope in that steering group. Next we actually said, well, we would like services to volunteer, they'd like to participate. So none of it was mandatory. Services had to put their hand up. Then we asked them to put their hand up of somebody who would participate as a champion within the service and a partner manager. So it wasn't just an individual, it was two people and there was management support. And then we looked at what we provide them in terms of support about training and what is the evidence. And we did that in part by looking up at the people in the UK who actually had done the work I showed earlier and had done training around recovery in older people. And then we provided them with some tools around change and quality improvement. And more or less we said, all right, go out there and do something. You choose where you're at. You know where your culture is at, what you think you can change, what would make a difference. And as a group, do something. And the really good thing was almost every LHG participated and almost every LHG achieved something. Some achieved a lot, some achieved a little bit, but everyone achieved something. And as a system, it's actually made a big difference. Why has it made a big difference? First of all, because the range of projects was quite varied. As I said, some are tiny, some are huge. We actually got the first studies actually looking at what peer work looks like for older people. Nothing internationally around it beforehand. Some are tiny, some are about an audit. Some absolutely would fit a co-design model. Some would have a traditional model, but they all moved forward. And having those discussions fundamentally changed the way that we looked at our community model of care. And that's our diagram, our overview of our model of care for our community services. Really emphasising that actually, for the older person, the vast majority of their care is not medical services. But medical services have to know and be able to integrate with the other services. But the person, and these symbols are their family and GP, remain at the centre and it's their journey where they're on the periphery of it. And then we do go into then what's in that circle on the side. But that happened because we're having this project as well as other things. And we've gone back to actually look at, well, did it make any did it make a difference in terms of the way we think? One way of looking at it is the way we write. And so what this is looking at two of our key documents before we did the project and two of the key documents after we did the project. And in a way, it's probably not terribly surprising that the word recovery is there a lot more. And that's good. but it actually doesn't excite me that much because it can just be a word. So what we also looked at though was actually, if we look at China as a model for recovery, we looked at those elements and saw those elements actually have changed as well. So it was the way we're thinking changing. And the nice thing is, it hasn't changed as much, but it very clearly has changed as well. So the approach has made a difference to the way we're thinking. And to me, it's the same change that we need with physical healthcare. Kate's actually gone through these. I'm actually would prefer people to ask the questions they'd like to ask in terms of any specific projects we've done. Because to me, the key lessons are that what is required for change. I've said for recovery, because we're saying we think it's the same things required for physical healthcare. We need a willingness to undertake the journey. We need to understand older people. We need to understand relevant illnesses and services. And by illnesses, the whole range of illnesses might be relevant. We need to understand what recovery means for older people. It's fundamental to actually how we can implement improved physical healthcare as well. And we do need access to services with the attitude and skills to provide recovery-oriented care for older people with mental health needs. We've got to do it daily. We've got to practice each day and doing it a bit better than we did the day before. And we need leadership. And we're going to do it in a way that we build up shared language, mutual respect, and hope. So I said I've gone from optimism to really think I'm not very good at all about physical healthcare to regaining hope that we can make a difference to physical healthcare for older people. And so what we're now encouraging our services to do is again think outside the square about how can they improve physical healthcare for older people using the same model as we've used for recovery. We're asking them, first of all, for volunteers. Yes, we've got a lot of volunteer service, or volunteers that tell us who are lining up. We haven't got the official put their hand up yet. We've got a lot of people who are energetic that want to make a difference, and we're going to ask them each to identify where, as a local service, so not as a big service, do they want to make a change, and to start somewhere. What we've learned though is we're doing it this time with evaluation built better in. So that hopefully out of that we can actually then feed back more about what we know makes a difference. And I might leave it there. Thank you.
Questions for Kate or Rod? Yes. So Kate, there you are. I just have to say that I'm very disturbed about the level of medication people are being prescribed. I just thought I'd say that.
It actually, can I explain that? One really good piece of news, if you look at, it's actually repeated the acts of variation, just looking at rates of prescription, and the only group where antipsychotic use has gone down has actually been for older people.
Right.
So only a small game, but it's at least in the right direction.
Okay, that's great. Jessie's just going to take the microphone over to that lady on the table.
Thanks for your presentations. It's very exciting to see that you actually got a framework for older persons' mental health specifically in New South Wales. We had a framework in Victoria in 1996 and nothing else since then. I think we've got two paragraphs in Mental Health Matters, the white paper. Physical health is absolutely mandatory to be integrated, but I'm wondering, as opposed to just looking specifically at mental health clinicians and mental health workforce, how can we translate that to our general health people as well? Particularly in acute inpatient units, the amount of people that get admitted, I didn't realise delirium was actually a mental health diagnosis, but that tends to happen. So people with behaviours of concern in medical general units come to our mental health units where they have 5 or 6 complex physical health issues, and they'd actually be better off being cared for in that environment with those resources, with perhaps some input from mental health assisting with that, as opposed to coming to a mental health unit and having met calls done every half an hour or whatever, or people who have behaviours of concern secondary to delirium or mental health issues being mechanically restrained in general wards and then shipped over. I just think that there's a gap. It's a very good starting point that for mental health professionals to be looking at this, but how do we actually translate that So we're really caring for people holistically and not stigmatising and not having people miss out on the physical healthcare because of those gaps.
I mean, it's been a very long journey in New South Wales, and I wouldn't say we've got it all right, but I'll say some things that may be relevant. First of all, there has been a hope that has been forever that you can unify mental health and physical health care for older people. It can work beautifully until the leader changes, and then it totally falls apart. So I actually don't think it's a systemic solution. Love it if you have it for a short period of time, but it's not going to keep on going forever. So therefore, we've got to keep on building better bridges. So the more we can understand each other's roles, the more we work together. It is then, and it's got to be at the top, and it's got to be at each level between leaders. I think the next thing is that in New South Wales, one thing that wasn't planned, but it's happened over 10 years, is actually, is it everyone or all but one, acute mental health service for older people has moved. Everyone that was not on general hospital site is now within a general hospital or on a general hospital site. So the more that you're together, again, the easier it is to actually do that care together. And the next is, and this is a bit heretical, so this is me, this is not policy. I actually think mental health, as I was trained, mental health care units for older people actually do great physical health care. And I think we need to get back to that as well, so that we do all the other work. We want people doing where their strengths are, but we should be good enough on both sides and to actually be able to handle the grey area.
Do you have any other questions for Kate or Rod?
No, look, I think clearly from those word maps you put up there, there's obviously something in terms of the whole community discourse that we have to change about older people, and I think that that's something we all need to think about, how we change that, because I think that's going to also impact on the number of people that are going to want to go into working in aged care services. And I've got a vested interest in this getting this better because I'm not getting any younger, so I think we all need to think about how we actually frame the conversations around older people. So can you thank Kate and Roddy and please? So I would like to introduce our third speaker to you. Don't mind, Catherine, I might not read all of this out just in the essence of time, but Catherine Johnson, improving the health of LGBTI+ people. What does early intervention mean in a landscape of social inequity? Catherine Johnson is a Professor and Director of Social and Global Studies Centre at RMIT and Visiting Professor, Centre for Transforming Sexuality and Gender, University of Brighton, UK, and her research is in the field of gender, sexuality and mental health, with specialisms in critical community psychology and psychosocial studies. I won't go over this.
Thank you very much and welcome.
Thank you.
Thank you very much. So I'm here today to talk about LGBT health, LGBT mental health. I'm a recent migrant to Australia. I moved over in August, so most of my work is going to be talking about UK-based research, although I think there are many parallels to the current situation in Australia. Okay, so I just want to start by, I suppose, give a kind of broader social context to what we're talking about when we think about the health and mental health of LGBTQ+ people. I am part of that community, and it's part of our history, our kind of queer kind of lives, our subjectivities, our sense of who we are, that is completely wrapped up in a history of discourses of mental health, high moral dramas about the individual sex act, and this dichotomous opposition between our agency, our choice, and a sense of pathology, deviance, and the epidemiology of risk. So that's a kind of a statement from David Halperin. And I want to use that sort of trying to frame how we always come to think about the health and mental health of LGBT people. And I quite like this newspaper article where we say psychiatrists have switched their stance. So homosexuals gain an instant cure. Because of course, if we remember, to actually be a homosexual was to be diagnosed as having a mental disorder. And what we've seen over the last 50 years is a shift from homosexuality itself being a mental disorder to diagnostic categories around being able to come to terms with your sexuality. So if you found it difficult that you were lesbian or gay, then that was also a mental disorder. To now a kind of more broader concern about elevated rates of mental health issues, suicidal distress amongst elderly populations, as well as, of course, health inequalities more generally. In my work, I've worked very much in the field of LGBT mental health, but I also work around LGBT's people's experiences of palliative care, LGBT's experiences of basically interactions generally with healthcare professionals and the kind of impacts that has on them. And as we'll see, whether or not those sorts of things shape the way that our health does kind of unfold through the lifetime, because if those experiences are negative, it means that people are less likely to go out and seek help when they might need help for their kind of health. So I think we need to think about that this legacy of pathology, social stigma and shame are still very much implicated in how we come to understand some of those disparities that we see within LGBT health and mental health outcomes. Okay, just to say a little bit more about the epidemiology of risk. We are an at-risk population. We seem to be at risk within kind of epidemiologies of HIV and AIDS, around suicide, suicidal distress, around depression. We have elevated kind of statistics in relation to smoking, alcohol use, obesity, particularly amongst women. So lesbians are seen to be at health risk in relation to their weight. We're around underweight, which actually is seen to be a health issue amongst gay men and also trans women. We also kind of have significantly different kind of uses of drugs, recreational drugs, and also a whole number of cancers where we are at elevated risks of a whole number of kind of cancers. Just to point out some of those figures, so these are taken from the Australian context. In terms of suicidality, LGBTI young people aged 16 to 27 5 times more likely to attempt suicide in their lifetime. Transgender people aged 18 and over are nearly 11 times more likely to attempt suicide in their lifetime. In terms of kind of diagnostic categories in the kind of mental health spectrum, LGBT people feature very heavily in relation to diagnosis of depression and anxiety. Just some statistics here on depression. So nearly 6 times more likely to currently meet the criteria for a depressive episode. This is than the general population, and 3 times more likely to be diagnosed with depression in their lifetime. We find consistencies with these sorts of figures, in most kind of countries where these kinds of kind of national studies have been done, which do a comparison with the general population. So, what sorts of explanatory frameworks are available to think about these disparities? Well, Myers' model of minority stress is probably one of the best known, where it talks about the impact of discrimination, bullying, isolation, and growing up in a family situation where you're not understood by your family. So Myers uses, I think, maybe in some ways a slightly clumsy comparison with if you come from kind of an ethnic minority, where you may have experiences of racism, bullying, etc., but you have a family to go home to try to talk to, which can give some kind of protector. But one of the problems with Myers' model is he doesn't actually, certainly in the early work, didn't really think about those sorts of intersections that actually you can come from both types of family. You can come from a minority ethnic group and also be LGBT. But it does give a kind of framework to think about why people might start to develop issues with their mental health in the context of kind of shame, bullying, stigma. We also know that amongst young LGBT people, they are much more likely to experience precarious housing, homelessness, which also then leads into kinds of elements around sexual exploitation. We find that sexual exploitation comes often also within queer communities, where young people will turn up into a city which is perceived to be a safer place for young LGBT people to be, and actually without having precarious housing, they end up couch surfing, which can then lead to kind of STDs, drug use, etc. So there's a kind of sense of a vulnerability around a certain age group where for others within the general population they might be receiving more support from a home environment at that kind of life transition point. All of those sorts of things can have an impact on education and employment opportunities. Often young people come out at the time, which is the time where at schools you're also doing exams and being assessed, which can make a big difference on your future opportunities. And then if they're not in a good environment in schools, then actually they can drop out of school or they don't attend enough, and then that has completely long-term implications in relation to their opportunities going forward for education and employment. It then impacts lifetime poverty, which we also know has profound implications onto people's health. We can also think about some of the explanations for those disparities in terms of social, cultural and gender norms around health-related behaviour. So in this kind of sense, so lesbians are often seen as being kind of overweight, and that has an implication in relation to their health. Now, sometimes people might explain that in relation to discrimination, but it could also be seen in maybe a more positive way about not having to live within the norms of heterosexuality, which expect the kind of slim, feminine body distinct from the kind of, the masculine, kind of Adonis body, etc. So there's a kind of freedom in that kind of sense there. So I don't want to just think about it all in the kind of negative light, but they do have implications, though, on health implications, which is why we find that lesbians are significantly more likely to use kind of dangerous levels of alcohol, smoking, weight, sorts of things that perhaps historically we might have associated with men's health-related behaviour. We also find that there's a kind of evidence that there's a failure to seek help in crisis due to a kind of double stigma. So this kind of notion that actually, particularly young people, we know that they leave it till things are really, really bad before they look for help. They don't ask for help at home, they don't ask for help at school. They'll look online, and it will often be when their mental health is in quite an acute state. So basically in the explanatory frameworks we're seeing a kind of mixture of things possibly related with lifestyle, maybe some of those cultural norms associated with a hedonistic kind of lesbian and gay culture, which can then long-term lead to certain kind of health-related problems. But they're also seen in relation to individual responses to dealing with inequality. So some of those things that that we might see as damaging for health in the long term are actually part of the coping strategy in the shorter term. So in my work, I work with community organisations primarily. So an organisation I've worked with for probably over 15 years now is called Mind Out, and they are an LGBT run by LGBT people, mental health support, peer support kind of organisation. Now, because we know statistically there's a lot of data around elevated rates of suicidal distress, we did some qualitative work with people living with suicidal distress around what was going on in their lives at those particular times, but also what sorts of things in their lives might help them live with their suicidal thoughts and feelings. So I just want to show you a couple of extracts in that kind of context of thinking about the relationship between health and mental health. So Simon, who did the keynote yesterday, will probably be pleased to know that we did find examples that physical activity can be a great coping kind of strategy for people who are living with suicidal distress and also substance misuse issues. So this is Christine. The project was people took photos of things that they found helpful in and around their lives, but also how they sort of felt about their mental health, in the kind of everyday. So Christine says, it's what keeps me going at the moment. This is climbing. You have no option to be in the moment when you're climbing. You can't think about anything else. It's just a great way. Your head's spinning. Everything is too much to shut it out. Whether you've got mental health issues or substance abuse issues, everything stops as soon as I start climbing. And then this is the second one, who's Rome, which I think again shows some of that complexity about the kind of the interaction really between health and mental health, and about what counts as a kind of coping strategy. So here we have a photo of kind of alcohol. We have a photo which is of kind of medication, McDonald's. And basically Rowan's talking about this kind of ambivalence really, about, you know, whether the antidepressants are actually helping, knowing that some of these things aren't helping, but actually it's part of that kind of everyday coping, things that people go to reach to when they're feeling terrible. Okay. So, just to say a bit about trans-specific. In Brighton and Hove, Brighton and Hove is actually, in some ways, an amazing place to live if you are LGBT. It's very kind of equality-driven and does a lot, which is in relation to supporting LGBT lives, but it doesn't mean to say that those issues are not there. So there was a trans needs assessment done in 2015. It's quite a high percentage of the population are trans in Brighton. It's a place that people kind of move to. But we found that they're more likely to have limited long-term illness or disability than the overall population, high level of mental health needs, lack of knowledge about health screening, higher rates of smoking, lower rates of physical activity than the overall population, and less likely to use parks or open space. So again, if we think about that in terms of the interaction between if we think about that in terms of the interaction between health and mental health, if people don't feel safe in public spaces, they're less likely to be physically active. So what can we do about those sorts of things? Well, one thing is that the city funded things like a trans swimming group. So this would be where the local swimming pool was closed to general public and once a week, and it was specifically for trans people to go along, because trans people often feel uncomfortable, in their body in those sorts of situations, in the general public situation, fears of transphobia, etc. So, these sorts of initiatives are, I think, these are good interventions that can help people kind of in that who are living with mental health problems or suffering with kind of physical health issues, to make them feel safe, to maybe take some of those steps to kind of engage. But what I want to kind of point out is that whilst we have these kind of interventions, this is always against a backdrop of kind of wider social stigma. So, just to point out one of those things that's taking place at the moment in the UK. So, I kind of debated over calling it a moral panic or public discourse, but basically it's both. But we've seen over the last kind of year or so, because in the UK there's a debate about the Gender Recognition Act going on, much the way that in Australia you had a debate about gay marriage. It's become this very kind of toxic kind of ground where it's become a kind of polarisation of rights. So which has had an impact really on how trans people can actually engage with physical activity. So it started at a kind of elite kind of public discourse around, elite athletes saying that trans women would have a competitive advantage if they're allowed to compete in sport, which then filters down actually to, so the middle thing is David Lloyd, which is a kind of well-known gym chain, that actually was asking people to show their Gender Recognition Act in order to be able to use the changing room facilities. So it's this kind of like proving who you are in relation to being kind of male or female. And then of course this makes it even more kind of less likely that trans people are going to try to kind of go out and exercise in those ways, which we then know can have longer term kind of implications in relation to their health and mental health. So that's just a sort of one example. Okay. Another example, so I've just begun with some colleagues at the University of Leeds and Lancaster and Manchester. We've just received a lot of funding from the NIHR in the UK to do a national study which is trying to identify early interventions to improve the mental health of LGBTQ young people. As I said before, we know that they don't seek help from family. We know that actually they're most likely to go online or talk to their friends. So we're trying to actually map what services are available and which ones are seen as accessible and appropriate young LGBT people, so that we can then develop commissioning guidelines for how services should be delivered, which then might improve the way that young people, LGBT people with mental health problems, will start to access services. So, I mean, and that's great, and it's amazing, that we have got to a point where those kind of health inequalities are being taken seriously, and there is funding, and hopefully funding afterwards, to provide the actual services to try to make a difference for young LGBT people's lives. But I suppose in that kind of question about early intervention, one of the things that's come up when we talk to our community groups, our community partners, is about the age at which they think this early intervention should happen. So they're talking about that these things need to be available from age 12. Okay, so we had originally thought, youth was looking at 16 to 25, but actually they want the interventions much, much earlier. And I guess there's that sort of question about, well, what does it mean then to intervene earlier, and what are we intervening in? Okay, and these are the sort of broader social questions, I think, which are important for us to always think about. So, second moral panic or public discourse, which again we've had here in Australia, is about what happens in school situations when talking about LGBT lives, okay? About whether they're seen as equal, as valid. So we've just had a very public debate about a school in Birmingham where they were delivering in their kind of sex education lessons, they were delivering LGBT-focused kind of understandings. This is a primary school. It's not actually about a sexual act between same-sex people, but it's about having examples where there are two mums or two dads. It's all fairly conservative, really, within the sort of family model. But anyway, there was a very large protest. Many parents stopped sending their children to school. The lessons are cancelled. But as we see, the public discourse also shows that there was this understanding that lives are ruined by shame and stigma, that LGBT lessons in schools are vital. And if we think about the history of kind of LGBT mental health and its kind of connections with living through those sorts of contexts where you learn from a very early age that you are not an acceptable thing, you don't see those kinds of models of those lifestyles around you, we have to see that as part of the problem of why there are these elevated rates of health and mental health issues. Okay, so to kind of put that into some broader question then, what might an early intervention look like? I mean, I suppose in some ways I'm sort of straying into the ground of what might prevention look like. And I think we'll probably hear a bit about that more in the next talk. But so I would like to say that it is, I think it's brilliant that we are finally seeing governments invest money in doing research about services for LGBT people. That we do access services in different ways. We do feel comfortable in different ways where our sexuality isn't seen as the problem, but it is also acknowledged in a way that makes people feel comfortable and relaxed. So it's really good that money's being put into that, but it's still very much, I think, that individualistic approach. It's about fixing something that maybe didn't need to be broken in the first place. So a social intervention could be earlier. And it could be actually about transforming those scripts of shame and stigma that are associated with queer lives and entrenched in us long before we know we are that thing. And I think that's from my experience of working around suicidal distress with young people and seeing that kind of their utter terror when they've been bullied at school for being gay and haven't been able to tell anyone that this bullying is happening, because they're frightened that they might be that awful thing that people are saying that they are. So it's, that we've got qualitative evidence which really demonstrates how these things become entrenched in somebody's kind of psyche. So, and in order to have this type of social intervention then really we need the action of friends, siblings, parents, teachers, therapists and healthcare providers to challenge the normative situations that enable homophobia and transphobia to persist. And I think that's particularly the case in families. So what we saw in the UK was a lot of people protesting, it's too young for my child to hear about LGBT kind of like relationships, because those parents do didn't for a moment imagine that their child might be that person who grows up to be gay. And you know, Twitter's a terrible thing and a wonderful thing, and you can find some great kind of tweets in relation to some of the things that came out, some very supportive things. So, and this one, he's a very well-known comedian in the UK. So I would love my son to be talking about LGBT issues in schools, so they don't grow up to become the sort of narrow-minded pricks that don't want LGBT issues taught in schools. And those are the sorts of things about that kind of the way that allies can kind of stand by and create those sorts of changes. And I'd just like to conclude with a happy note that in the last couple of days that there was a debate in Parliament in the UK. It went much better than any of the Brexit debates, which don't seem to have any kind of resolution. It was unanimously approved. I think only about 20 MPs voted against it. Over 500 MPs voted for that there should be LGBT inclusive sex and relationship education from primary school. Okay. Thank you.
Thanks, Catherine. That was fascinating. It's just made me realise throughout the course of this whole conference we've heard so many things about good leadership actually makes a difference. So I'm going to go on the Hove. I think it's wonderful. Does anyone have any questions or comments for Catherine? Well, I found it fascinating, so thank you very much, and thank you for your good work. And it's a real area that we need to encourage our children so they're safer. So if you're going to keep doing that work, I'm very happy and very proud. Thank you. Okay, so a man who's familiar to you all throughout the course of this symposium is Russell. And I won't bring this all out, but I will say that Dr. Russell Roberts is an Associate Professor at Charles Sturt University and Adjunct Clinical Associate Professor at the Sydney University, and he lives in Orange. Welcome.
Thanks, Kevin. Thanks, everyone. I'm going to get straight through, and I do have some questions for Catherine and Rod and Kate. I'm going to get through this really quick, and then I want to explore some issues with the people at this session. So I'm just going to go through a few slides, present a framework, but then try and develop, get some ideas back and to explore some of these ideas. Because some of the things about promotion and prevention are about trauma, they are about inclusivity, and that applies across all the topics we've talked about, today. The one other thing that's remiss of me is like, a wedding speech. Yesterday, I didn't acknowledge firstly Jackie Crow, who was really instrumental in the Equity World movement and getting that started, but also Beverly Raphael. And Beverly Raphael was partly responsible for coming to New South Wales, and in more ways than one, she interviewed me when I became an Executive Director of Medical Services, but also from the 2000 monograph on promotion, prevention and early intervention that she wrote. So it was Aaron Gross whispered in my ear and said, well, I didn't realise Beverly was behind that, but she's certainly behind this. I also acknowledged Rod McKay, who wasn't here yesterday, but his work decades ago that Rod referred to. Now, this is the thing. The issue here is a lot of this stuff is preventable, and we've talked a little bit about the physical illness and the physical side, but I want to open this up a little bit more in terms of starting to think about a model of promotion and prevention. And we've talked about all the risk factors. That's in the Equity World Consensus Statement. Sorry for people taking photos with Twitter. But, across all of these, the 12 to 15% of people with mental illness, more of those people die than the entire rest of the 85% early of physical illness. We know this. It's an issue and it's a human rights issue. But even more so, for certainly if you're rural, but if you're not participating, if you're not in any paid employment, this says something, I think, Catherine, about inclusivity and community participation. More, for every one person who dies of suicide, early suicide, of course, 10 die early of cardiovascular disease, cancer, or respiratory disease. And it's not as shocking, but it's just as tragic. These people also have families, and they're dying 20 or 30 years earlier. And normally, that's preceded by years or decades of poor physical health and functional disability. So it's really important for us to think about how we can get in early, promote, prevent and get a bit of a model of that. We've talked a little bit about this already, and the importance of improving physical health actually is now becoming one of the go-to recommendations for improving mental health. So a lot of the recommendations say, if you want to improve someone's mental health, go and focus on their physical health, because you're likely to have the best effectiveness. Likewise with suicide assessment, it's almost standard. You do a suicide risk assessment, the biggest risk is early death from physical illness. You should be doing physical health risk assessment. We talked about diagnostic shadowing. Equally well, consensus statement. The second element is effective early intervention, promotion and prevention. What does this mean? It hasn't been unpacked, and I hope that we can do this a little bit today. We've talked about that too, that there's a bit of a transition here. So there's a period here where comorbidity is really low, and then a bit later it becomes really high. What's happening in the middle, and how can we intervene early? Or how can we intervene, and I'll explain what I mean early, through the entire lifespan. Early doesn't mean young necessarily, it means early, and that's at any stage. It can be at 85 years of age or at 5 years of age, and that's where I'm going to go with you, Catherine, in terms of should it be 12 years of age? Well, let's talk some more about that, because I think it's a great conversation, by the way, and thank you for your presentation. This was the model, and I think Beverly Raphael referred to this in 2000, monograph on promotion and prevention. And you intervene across a spectrum of illness for mental health promotion and prevention. It's a Mrazak and Haggerty model that a lot of you are familiar with. It's okay, but it's just part of the spectrum. But there are some issues with that. It starts with prevention, moves into early intervention, and then on to treatment. And this is the model, universal through to selective, through to long-term care. And that's a model that's been out there since the late 80s, I think early 90s, 1990 I think the reference is. But that overlooked the social determinants. If we're thinking about early intervention and prevention, what are the social determinants of health and well-being and the biological antecedents and social issues and social equality, which Catherine was talking about? It doesn't help us too much in terms of what do we do at all different levels as a clinician, as a social policy person, as a social equity campaigner. What do we do about this? And it doesn't inform across the spectrum of care from universal promotion through to people who have severe and enduring mental illness across that spectrum of health and ill health. The other thing is the language, and it's been referred to, well, what do we mean by primary prevention, secondary prevention, tertiary prevention? And how does that work with early intervention and prevention and all of that? So really what we did in my time as chair of the New South Wales Promotion, Prevention and Early Intervention Committee is try and nut this out and make something that was usable and understandable. So we looked to sort of develop some plain language definitions, and we had this table I won't go over too much before, but we actually put it in action language. Actions to promote mental health and well-being. Actions to prevent the onset of illness. Actions to intervene early to reduce the duration and severity. And this is in mental health. That was a mental health committee at the time. Actions to reduce the ongoing impact of mental ill health. Now, if you're like me, that was when it was a mental health committee. But I've evolved since then. That was about 2005 to 2010. My watch is going too, but that's all right. We'll just turn that one off. Sorry, the phone's going off. Luckily, it's on silent. But for us, we have to think about, well, what about today, about physical health? So let's talk about this model a little bit. So this is the model that we came up with. So in terms of what's primary prevention, well, primary prevention is essentially the actions of the New South Wales policy. Now, firstly, there's actions to promote health. The very first thing we should be doing is actions to promote health, and that's where I'm going to invite you to come in, Catherine, a little bit later, to think about how we promote health in all communities, and some of the actions we can do this society-wide to promote health, and really anyone who's sort of following that, I think it's sort of pretty straightforward. Then there's actions of primary prevention, which is the actions to provoke onset. There's two categories there. It's a whole of community, but also there's groups at high risk. Catherine's identified that, the LGBTI plus are a group that's high risk. So are people who suffer trauma, so are people who are homeless, so are people with low SES. So what are the actions we've already identified the high risk, so what are the actions that we can get in primary prevention? Secondary prevention is the same as early intervention in the nomenclature. So what are some things we can do who are at high risk, high identified risk, but also early signs, the signs of early poor well-being and mental ill health are there, and also people who are experiencing their early first episode, and that's where the bond group, the Bondi group, are doing with the early intervention for young people with psychosis, etc. And then there's tertiary prevention, which is actions to reduce the impact of mental health. I looked at this model and thought, this is a mental health model, but we can really apply this to physical health, can't we? We can really just change this to this. Actions to prevent the onset of physical ill health. When we think of people who are at risk of mental illness or have mental illness, those sorts of actions. Actions to reduce the duration and severity of physical ill health. Actions to lower the impact of ongoing ill health. So when Indigo was talking before in terms of early medication, etc., there were actions there that could have happened to stop them putting on those 50 kilograms. There was actions to sort of keep it fit, and Simon talking about actions about keeping people physically fit. And then we've got the issue of people that are enduring an ongoing mental illness, and Simon was talking about that as well. So, luckily for you, I'm going to stop talking in a sec. So this is sort of, when we start to think about this in physical health, this is a bit of a framework we can think about in terms of using that language for physical health. But I'm now going to throw to you in terms of, and this is in terms of what Nehemiah was talking about, in terms of an example of a way that we can conceptualise this, because the next question is, what do we do? The question for Equally Well is, what are you going to do differently? You do what you can, where you can, when you can. And for each person that's different. We all have a different role. I encourage you to get the slides and say, for Equally Well, I am going to do this. For me, I'm going to put together a submission to the Productivity Commission about we really need to address this issue. But for everyone, it's a different action you can take. So what are the actions that you can take? Well, hopefully we've got the roving mic here. So there's physical health actions. What are some of the actions that we could take to promote health and well-being? What are some of the domains that we could look at? Nehemiah used the 28 domains out of the World Health Statement for physical health. That's a little bit complicated, I think. But what would be some of the domains, and I'm going to ask for people to suggest this now, what would be some domains where we say, this is what we could be doing now to promote physical health, in terms of mental health and physical health promotion? Kim? No, 5 minutes. Right.
I'll start by being controversial. If you go back a slide, sorry, 2 slides. You love the picture.
Back again.
Surely, if we really want to get to grips with this, that should just say actions to promote health. It should be physical health, and we should get away from the physical and the mental, because one of the great blocks is people still do see their primary role in physical or mental, and maybe that's the starting place. And if you want to take an example of where that's working, if you want to think about something that we think we can't prevent and is debated whether it's mental illness, it's dementia. And yet we now know good data from the UK, and there's some service data that's published in Australia that's supportive but not as strong, that says we actually probably have reduced the population rate of dementia, and it's probably through the physical health of the community.
It's an interesting debate, isn't it? Because then there's the whole issue of well-being, and is well-being more than just health? So what would you call your spirituality, your connection to the land, your connection to your country, your connection to your culture, connection to your gender identity? Is that health or is that well-being?
No, definitely health and well-being. I wasn't saying take the well-being out, but whether it should all be though about health and well-being, you shouldn't have physical or mental.
Take the physical out?
Take the physical out.
Okay, yeah. So
it's just
health
and well-being.
And well-being. Yeah. No, great. We'll move back forward slides. Thanks, Rod. I mean, that's a great point. And it does raise the other point of talking just about physical health, and I think that was your point too, Catherine, just focusing just on physical health and mental health as conditions is not enough. I think that the foundations are in a social and inclusive culture. And when you were talking about, 12 might be the age, and I think you alluded to it as well, I was thinking, well, maybe it's 3 or 4. And setting those templates of, well, is it okay to have 2 mums and 2 dads? And is that just another thing? Is another form of family which is equally okay, and it's not even commented on. That's 2, 3 and 4 is when that sort of mental template starts, and that social inclusivity. Is it okay to be from a different race or a culture? Yes, it is. So it's all of that is the not okayness. I think, it's such a great presentation, that is the seeds of poor mental health and that social exclusion. I'm not an accepted part of this community. So that's the part of being, a world that I'm connected and I'm valued and I'm equal. And it's such an important part. And I'm so pleased that we had the discussion. And I think Rod and I we came up with the term equity well ourselves, independently to the New Zealanders, but the New Zealanders got to us 2 years before us, but there might have been some seed there. But the equal stuff is really important in this. I think for the physical health and the, because there's been no hands up, so we're going to sort of fill the gap. So if you don't talk, I'll fill the gap. I think it's pretty clear, in terms of, prevention of cancers, prevention of cardiovascular disease and respiratory disease and diabetes. They're the sorts of things that you'd be looking, how do I prevent that straight away? And then when there's early signs and the risk, how do I get in to prevent the risk? When there's first signs, how do I get in with interventions to minimise that? So in terms of those actions to prevent the onset of diabetes or cardiovascular disease or respiratory disease, which are the big early killers, I think that's pretty clear, and we've got methodologies for that. So I think the challenge is for people and the clinicians to work up a bit of a model, but to think about this. This is probably one of the most important things you can do. For every 2 people you convince to stop smoking, you will save one of their lives. You will give one of them 20 years of additional life. That is a great gift. If you said to someone, I'm just giving you another 20 years, and someone did that to you, you'd say, that is an amazing gift. So for every 2 people you convince to stop smoking, you will gift one of them 20 years. And it's the same for a number of the other risk factors in terms of physical health. It's so important to intervene early, promote and prevent, because you are giving people a gift of years of life and health. What about the social and environmental factors? Rod and then Stephen.
I think there's something fundamentally we can do which is done better at the start and the end of the lifespan, that something goes drastically wrong in the middle, is actually regular contact with the GP. And particularly diabetes, the evidence is building and building about the fact that early joint consideration of anxiety, depression and diabetes risk factors has got this wonderful cycle of improvement. The only way we're going to do that is if we are from within the health system, within the consumer movement, we are at the point is towards in Australia where we have got the GP at a crucial point to really be using that.
Thanks, Rod. Stephen, did you have your hand up? Yep. And then I want to ask Catherine a question I noticed in terms of social and environmental factors. What would be areas that you would recommend that in the mental health field we should be thinking about and focusing on?
I'm just going to comment on the great presentations, and also just on the area of polypharmacy, and also I guess my concern of lack of algorithms for especially psychiatrists in the management of metabolic conditions. It's often, especially in rural communities, it's where I'm part of, it's such a difficulty accessing the chronologist on site. What's being done to get that care immediately to that patient is something that I'm pointing to. That's 1.2, and also I guess, when do you start lipid lowering therapy, for example? When do you cut off that? not just for a patient with hypercholesterolemia, but for a patient with risk factors of, especially with polypharmacy in the background. Was, yeah, it's probably where I was trying to take.
Catherine, did you have I'm just conscious of the time, we've got like 2 minutes, is that right, Kim? 1 minute. Catherine, did you have any comments or suggestions around that social environmental factors that you wanted to add?
Well, I think that in the kind of sense of the early intervention, I suppose that's what I'm trying to say about with school situations, that if you start very early in life and that people don't develop a sense of themselves and it rooted inside themselves as being something wrong, so they then have that narrative of a struggle to come to terms with who they are, etc., etc. I think in the public domain, not having debates about people's rights to exist would have a positive impact. I do agree with you though about that midlife thing. My work is around LGBT kind of well-being, is that actually often there are people who come out midlife who haven't come out early, and there isn't much done about that because most of the resources are being pushed into young people and young people's mental health with that kind of assumption that if you can tackle something early, then they will have a longer life, and then you get this sense of, well, what happens if you're in your 30s or in your 40s, and the reason you didn't come out was because of shame, or it may be people's narratives might be about being very committed to religious communities and being worried about what the impact that would have. So then there isn't much going on to pick those people up, and I suppose there's maybe a history within psychology, which would go back to Freud, which is basically there's no point bothering once you're past 40 because there isn't any kind of change. So they might be wanting to sort of tackle some of that kind of element in the sort of midlife issue.
Yeah, no, thanks, Catherine. And I think I encourage people to think across your domains, at every level that you go. So, for example, some of the social environmental factors I was thinking about is, violence. Are they in a safe environment, or are they going back to a domestically violent situation? Safety, physical safety of the community, and certainly around areas where I was working with Kenya, etc., there was difficulties with that. Homelessness, social inclusion, social participation. These are the sorts of things we should be asking and taking a point before, looking positively. And look at the positive aspects to say, well, what are your life goals, etc. And so trying to address some of those things. So what do we do? It depends at whatever level you work. But even that constellation model, every time someone says racist or exclusionary, say that's not okay. Every time someone picks on someone, bullies on someone, you, as a bystander, says that's not okay, and stick up for them. That enhances everybody's well-being. It's a small thing, but it's changing the universe. But we've got people here at other levels who can advocate across your services and change service practice, advocate politically, advocate socially. And so everything we do makes a difference. And so we can promote, prevent and have early intervention across all of those different domains for people with a mental illness to prevent the poor physical health outcomes that we've got. So I'd encourage you when you go out there to say, think about this in terms of the action, what you're going to do on Monday to improve the physical health. And across all of these domains, there's so many opportunities that you can't pick one. I can help you with that. But thank you so much.
Thank you, Russell. Not only has leadership come out through the course of this symposium, the other thing that I've noticed that's come out of this is this a need and a sense for people to belong in our community, and that goes to all of the groups that we're talking about our older people, we're talking about our different populations, talking about people with mental illness, people with physical health conditions, homelessness. One of the biggest things that impacts on people's mental health and well-being is a sense that they don't belong. And we even talked about that yesterday in terms of people that were smoking, feeling that they don't belong in a community now because they smoke or the groups around them don't smoke. So I think this whole sense of us needing to belong, and we should all want to belong, and we all need to belong for our health and well-being, has been a really important conversation, I think, throughout the whole of this symposium. So can I thank all of our speakers once again, and enjoy lunch.